Welcome to our Facebook Live, when UC Davis health experts provide information that you want to know. We are discussing a very timely topic today, as October is Breast Cancer Awareness Month. I'm Pamela Wu, and with me today is Dr. Helen Shu, Professor of Medicine and Director of the Clinical Breast Cancer Program at the UC Davis Comprehensive Cancer Center. And today we're going to be focusing on various aspects like risk factors, symptoms, treatments for breast cancer, and if you have questions for Dr. Chu, this is an interactive party, please post them in the comments and we'll answer them at the end of this discussion. Thanks for being with us today.
I'm glad to be here.
It's October. What does October Breast Cancer Awareness Month mean to you?
Well, I think it's a really important time for people not only in a cancer center to think about breast cancer, since it's so common and it's generally affected everybody. So we do it on a day-to-day basis, so my colleagues and the people I work with and the wonderful staff we have at the cancer center. But it's a way to focus breast cancer everywhere else, so you are able to see it even outside of a clinic setting, and it's a way for, I think, people to think about it, to think about what it means to them personally or to their family, and to just be aware of what's going on, some of the progress we've made. Maybe it will remind some people to go and get their screening mammograms. So I think it's a special time to kind of focus on that.
Yeah, let's hope so. And I know that the Cancer Center in October has offered some extra Saturday dates for mammograms too, which is great. There's not just one kind of breast cancer. What are the different types of breast cancer?
So we can answer that in many different ways, but I think probably the most relevant way for people who are interested in this is to think about it as those kinds of cancers that respond to hormones. We call that hormone receptor positive breast cancers, to those that are something called HER2 positive, because we have very specific treatments for that. And for those tumors that don't have hormone receptors or lack HER2, we call that triple negative. That's a sort of easy, simplified way to think of it in a clinical setting. You know, there are other ways to answer that question in terms of what doctors in the lab see under a microscope, but I think that's probably the most relevant way to think about it.
How common is breast cancer in women? Let's start with women.
Yeah, unfortunately, breast cancer is very common in women, and in a Western country like the United States, it's the most common invasive type of breast cancer. So it's more common than lung cancer or colon cancer, for instance. So it's the most common breast cancer. You might hear the statistic 1 in 8 over your lifetime will develop breast cancer. So that's about 11% or so of women by the time they are older will have had a chance to develop breast cancer. And it does occur in men, but is much less common in men, and we see about maybe over 2,000 cases in the United States per year.
So quite rare.
260,000 cases in women per year.
You do have some male breast cancer patients, do you not?
We do. We always have, I would say, a handful, probably between my colleagues and I, of men with breast cancer. Many of the faculty here also have some clinic time at the Veterans Administration Hospital, the VA hospital, where they also see men with breast cancer.
But rare among men, and
very rare,
and very prevalent among women. When you say 1 in 8, I mean, think about all the women in your life who you know. 1 in 8, an eighth of them. That's a lot.
It's a lot, and I think that's why when we talk about breast cancer, it's really hard in any venue not to meet someone that it hasn't touched through a family member or a close friend or family or neighbors.
What are the risk factors? What should people know about risk?
Well, one of the strongest, but thankfully somewhat rare, is a genetic risk. So you may be hearing more and more about genetic testing and genes that people can pass on in different generations within a family. The common ones, or the more prevalent ones, are ones called BRCA1 and 2.
Yes.
Sometimes people call it BRCA1 and 2. But really there are many, many more not as commonly affected as those two genes. So genetics is a big thing, although we think it only affects about 10% of those patients that have breast cancer. So then we think about other risk factors which aren't quite as strong, but have to do with maybe estrogen exposure, starting your menstrual periods very early, or keeping your menstrual periods going very, very late, taking extra estrogens, we call that exogenous estrogens, in the form of birth control pills or hormone replacement therapy, which these things are a risk factor. They lead to a very small increased risk individually, but that's what our science has pointed to the most often outside of genetics.
Is there anything then that people can do to reduce their risk?
So if you happen to belong to a family in which we suspect there might be a genetic component, and generally we think about that as having an affected member, someone with breast or maybe other cancers that are related in every generation, or a first-degree relative, so a woman who may have a sister or sibling, a parent, grandparent, we see that in many generations, that family might consider genetic counseling and testing. And then there are some risk reduction options for them that range all the way from surgery to participating in trials to lower the risk. For the rest of the general population, I think limiting extra estrogens that you don't need, so certainly we think twice about giving a postmenopausal woman hormone replacement therapy. We think of the reasons why they may or may not need it. We try to keep that as short as possible so they get the benefit, but don't expose them to long periods of exogenous estrogens. And then not really in terms of prevention, but maybe finding things as early as possible. What we call early detection is through screening, such as getting your mammograms.
Yeah, and we'll talk about screening in just a moment. What are the symptoms of breast cancer? Are there symptoms that one might just be able to detect on their own?
So the most common would be what we call a painless mass on the breasts. And fortunately for breast cancer in this country, over 90% is diagnosed at an early stage, meaning that the cancer is limited to the breast or to the lymph nodes in the underarm that drain the breast. So that could be stage 1, 2, or 3. Less than 10%, the latest data show about 5 to 7%, at the time they're diagnosed actually have cancer outside the breast, let's say to other organs, like the bones or the liver or the lungs. So the vast, vast majority in this country, it's limited, breast cancer is diagnosed and limited to the breast or the underarm lymph nodes, and so it's generally maybe an abnormal lymph node, maybe a lump in the breast is the most common. There are other situations where there may be skin changes in the breast, where someone might think there's an infection, but the infection doesn't go away. If there's changes in the nipple, retraction of the nipple, changes in the skin, those could also be signs as well.
October is Breast Cancer Awareness Month. We are talking with Dr. Helen Chu, Professor of Medicine and Director of the Clinical Breast Cancer Program at the UC Davis Comprehensive Cancer Center. And if you're just joining us and you have a question, please feel free to leave it in the comments. We touched on screening for just a second, so let's talk about mammograms. What is the current recommendation on screenings?
There are slightly different recommendations depending on the group, but for instance, some very large groups that make recommendations include the American Cancer Society and the U.S. Preventative Services Task Force. And in general, they recommend that women consider starting screening around the age of 40. There's a little bit of controversy between the ages of 40 and 50, really more because of the prior data being stronger and more robust, with more numbers of women who are aged 50 and over. But certainly both of those groups recommend that you can start screening beginning at the age of 40. The only caveat to that would be if you happen to be in one of those families and there's a known genetic mutation, such as a BRCA1 or 2 mutation, we may start earlier.
Okay, so since there's some fuzziness around it, it would seem that the best advice would be to ask your doctor?
Ask your doctor, and also I think to reflect on how you feel about screening. So some people are very convinced they want to start very early, and others probably are not as convinced. And I would say it's certainly reasonable to think about it sometime in your 40s. I don't think it has to be an absolute for you to start at 40.
Okay, and then so start around 40-ish, between 40 and 50 at the latest.
Yes.
And then how often thereafter?
Generally, it's every year.
Okay.
So every year you should have a mammogram. If there's something about the last mammogram that was just not quite right and the radiologists want a closer follow-up, they will actually say come back in 6 months, but that's very specific.
What about self-exams? I remember there was, for a long time, a very strong push for self-exams. What are your thoughts on that?
I think we should always encourage women to do self-exams because I think women and really men know their bodies the best. And although it's not very, very common, there's a certain percentage of cancers that are not picked up by mammograms, as high in some series or studies as 10, maybe even 15%. And so I think it's not unheard of for a woman to have had a normal mammogram and then months later feel something herself on the breast. So it's something we certainly encourage. Of course, there's no data showing there are no studies of, well-done studies or large ones of doing self-breast exams versus not in this country or in the Western world, where there's also the availability of mammograms. So we don't know how much it adds to it, but I certainly wouldn't discourage women from doing a self-breast exam. Many times they pick up their own cancers.
Sure, yeah, it can't hurt. And like you said, you make a really good, you sort of know your body, and
Yes.
you know yourself better
Right.
than anybody else does.
Right, absolutely.
What are some typical treatment options for breast cancer? Maybe specifically you could talk about treatment options here at UC Davis.
Sure. Well, I think that one of the advantages of being at a comprehensive cancer center is that we do have access to a lot of other researchers. We have access to a breadth of clinical trials. So I think that really sets us apart from other places, and they would be early trials for people who've had lots of different treatments, and maybe their options are narrowing, to even very mature trials where drugs may be FDA approved shortly. So we have that whole range of clinical trials. There are trials in screening. There are trials in trying to minimize surgeries and minimize who needs radiation, who even needs chemotherapy. So if we go to just the general treatment options, I would go back to the types of breast cancer. So we have hormone blocking therapy. Through clinical trials, we've learned about women who don't benefit from chemotherapy and can be very successfully treated with only hormone blocking therapies. We have participated in trials in triple negative breast cancer. That's where you can't use hormones and you can't use HER2-directed therapy. It's only chemotherapy, until this year when there was a drug in the immune therapy group of drugs that have been used in other cancers that's now approved for breast cancer. And we continue to offer, I would say, standard treatments, but also a way to advance the field in terms of offering treatments that are not yet available elsewhere.
Hearing you list these off really strikes me at how much is available here. We were just looking at the numbers, and UC Davis Comprehensive Cancer Center is one of only 50 designated comprehensive cancer centers in the country. So it's really a resource for folks in this area.
It absolutely is, and especially in the Northern California area, all the way up to the Oregon border and east into Nevada. I think we serve as a resource for this catchment area.
What's happening now in research or breakthroughs? Like, what's next? What's to come in terms of cancer prevention and treatment?
I think what I would like people to know is that you kind of hear the term personalized medicine a lot, and I think sometimes it gets used so often it might get diluted. But I think when we think about those kind of three major categories of breast cancer, the hormone receptor positive, the triple negative, the HER2 positive, even within those subgroups, we're really identifying other genetic characteristics. So I want to think of it as slicing that pie into smaller, more specific pieces that allow us to really tailor treatment very specifically for a patient's cancer. We're not there 100%. Some of the breakthroughs and some of the new medicines that are very targeted affect a smaller percentage of patients, but I think that's what I have been able to observe and really be able to enjoy since my training to now being at UC Davis for almost 20 years.
Yeah, that is just amazing that it's becoming more and more precise to you.
Right. And I think we're seeing that not only in breast, but other cancers as well.
Do you have any final thoughts you'd like to share with us, or anything that you want people to walk away with after this discussion today?
Well, I'd like to really end on a positive note, because I think that's really where the direction we're heading. I think, if anything, over the last couple of decades, anyone who's had a loved one that's had breast cancer many decades ago, they know that now we do less surgery, both in the breast and the armpit area where the lymph nodes are. We can give less chemotherapy, and we have more precise drugs. So I think we're trying to get to a point where we are delivering better care that's less toxic and less disfiguring. And I think we always encourage those appropriate patients to participate in trials, because that's how we make these advances.
You sound optimistic. Is it okay for me to say you sound optimistic?
I'm very optimistic. I've been in breast cancer and cancer in general for a long, long time, and I think the last couple of decades in breast cancer and other cancers has really been amazing in terms of progress.
That's fantastic. Dr. Chu, thank you for being with us today and sharing this great information.
Thank you.
And thank you for joining us for this UC Davis Health Facebook Live. If you have more questions about breast cancer, Still feel free to leave them in the comments, and also feel free to share this post if you have friends or family that you think would be interested in learning more about breast cancer and UC Davis Health. For more information, do visit the website of the UC Davis Comprehensive Cancer Center. It's at health.ucdavis.edu/cancer. Thank you for joining us.